Hello, everyone. Thank you for standing by and welcome to our webinar, Early Pregnancy Screening, New Research and Non-Invasive Testing, sponsored by IsisParenting and presented by Dr. Diana Bianchi. My name is Chris Just, and I'm the Executive Director of Prenatal Education here at ISIS, a certified nurse midwife, and your moderator for this evening, along with Nancy Holtzman, VP of Clinical Content, Pediatric Nurse, and IBCLC, who will be typing with you in the chat room. During the presentation, all participants will be in a listen-only mode. However, you may submit questions to the speaker at any time by typing them through the chat feature located to the left of your screen, or direct them to us on Twitter using our handle @ISIS_parenting. We'll also take questions at the end of the presentation. Today's webinar is being recorded, and all of you will receive a link to the recording early next week. So if you missed something or need to step away for any reason, that's okay. IsisParenting is proud to host this evening's webinar. ISIS is the nation's most trusted prenatal and early parenting destination. We provide innovative programs and a highly edited selection of products for expecting and new families in our 4 Boston area centers and online at IsisParenting.com. As I mentioned, I'm Chris Just, and I'll be your moderator tonight with Nancy Holtzman in the chat room. And now it's my pleasure to introduce our presenter for this evening. Dr. Diana Bianchi is the Executive Director of the Mother-Infant Research Institute at Tufts Medical Center and the Natalie V. Zucker Professor of Pediatrics, Obstetrics, and Gynecology at Tufts University School of Medicine. She is also Vice Chair for Pediatric Research at the Floating Hospital for Children, Boston. Dr. Bianchi received her MD from Stanford University School of Medicine. She received her residency training in pediatrics at the Children's Hospital, Boston, and postdoctoral fellowship training in medical genetics and neonatal perinatal medicine at Harvard. She is board certified in all 3 specialties and is a practicing medical geneticist with special expertise in reproductive genetics. Dr. Bianchi has extensive research experience in non-invasive prenatal diagnosis. She has published over 230 peer-reviewed articles and is one of 4 authors of the book, Fetology, Diagnosis and Management of the Fetal Patient, which won the Association of American Publishers Award for Best Textbook in Clinical Medicine in 2000 and has been translated into Japanese, Mandarin, and Spanish. Dr. Bianchi is recognized locally, nationally, and internationally for her leadership roles. She is Editor-in-Chief of the international journal Prenatal Diagnosis and is past president of the International Society for Prenatal Diagnosis. She recently co-chaired the Scientific Program Committee for the 12th International Congress of Human Genetics meeting, which attracted 7,500 participants. Welcome, Dr. Bianchi.
Thank you so much, Chris, and Nancy is here as well. Getting used to the slides here. I'm going to be talking tonight to you about prenatal genetic diagnosis and about some of the new options in non-invasive prenatal diagnosis. And before I start, I just wanted to disclose that I do have some potential conflicts of interest. I'm chair of the Clinical Advisory Board of Veronata Health, and I do have some financial relationships with the company, but tonight I am speaking as an academician, and I'm also speaking from the perspective of having 30 years of research experience in prenatal diagnosis. So with that said, let's go ahead and start talking about prenatal diagnosis. Many of you have had prenatal diagnosis, and you've been through this experience, but some of you have not, and you're considering whether or not to have prenatal diagnosis. And I just wanted to remind everybody what the objectives are of prenatal diagnosis. So most importantly, those of us who provide prenatal diagnosis, and these could be a variety of different healthcare providers, it could be physicians, nurses, or genetic counselors, we're all providing information to prospective parents regarding the possibilities of fetal diagnosis. And no one can just give information without also providing an opportunity to have counseling and support for prospective parents for reproductive decisions. And people always ask me, what would I do in their situation? And I always say, it's not what I would do. It's my job to help you decide what you want to do. Now, in addition to diagnosing conditions, ideally, we'd like to be able to offer fetal therapy in order to prevent postnatal medical complications, and I'll be talking a little bit about that at the very end. The focus of tonight, we could talk about prenatal genetic diagnosis for a number of conditions, but tonight we're going to focus on screening for Down syndrome and other chromosome abnormalities because that is part of standard prenatal care. Now, I hope you can see this. It's actually a little small for me, but we can make it full screen. Great. What I wanted to do here was just give you an overview of the timing of different prenatal diagnostic tests during your pregnancy. Those of you who've been through this will be a review, but those of you who've not undertaken a pregnancy yet might find this helpful. You could potentially have a number of different ultrasounds during your pregnancy. An early one is usually done to date the pregnancy. And then at about 11 weeks in the United States, there's an ultrasound in combination with first trimester screening for Down syndrome, which I'll go into a little more in the next few slides. The first opportunity for an invasive test is a test called chorionic bill sampling. That's done in the first trimester, generally around 11 weeks. If you don't have first trimester screening or diagnosis, you would have second trimester screening or diagnosis, and that can consist of a blood test, generally around 16 weeks of gestation. And if there are abnormalities in that blood test, you might be advised to have an amniocentesis, which I'll explain in a few moments. In addition, most women in the United States have a scanning anomaly ultrasound test, usually around 18 to 20 weeks of gestation, and that is looking for structural problems in the fetus. And then the last thing that's mentioned here is cordocentesis, which involves putting a needle in the umbilical cord of the fetus. That's generally done to get a sample of the fetal blood, and it's only done under very rare circumstances. So in general, it's not something that we discuss with most pregnant women. Now, just to give you an overview of prenatal diagnosis in the United States, and I realize that some of you actually are not in the United States, so take it with a grain of salt because we're mainly talking about the United States here. We have about 4.1 million births per year, and it is a standard of care that all women receive information about prenatal diagnosis for Down syndrome. That's a decision that the American College of Obstetrics and Gynecology made, and it is considered to be a standard of care. Now, all women get the advice about the options for testing and screening, but only about 62% of women decide that they want to have the testing, and that's in 49 of the states in the United States. Interestingly, California is a little bit different because of the way the California state program works. And because of that, they have a much higher uptake in the initial screening tests. But ultimately, this results in 2.6 million maternal screens per year, which are divided at different points in pregnancy. So 16% of women have only first trimester testing. 20% of women have a combination of first and second trimester testing, which is called the integrated testing. And the majority of women in the United States still have second trimester screening, which is 64%. This would look quite different if we were talking about countries in Europe, for example, where the testing is primarily done in the first trimester. We'll go over how you can use that information to decide whether you want an invasive test, such as amniocentesis or CVS. But ultimately, about 200,000 women in the United States choose to have an invasive test each year, and the majority of them are amniocenteses as compared to CVS. And that has to do a lot with the fact that many doctors in the United States do not have training in the technique of CVS. Many more are trained to do amniocentesis. And amniocentesis has been around a lot longer, and there's a lot more experience with it. So this was just one of the American College of Obstetrics and Gynecology practice bulletins, which recommended that all women get screening for fetal chromosome abnormalities. There was a subsequent bulletin that said that all women should be offered diagnosis for fetal chromosome abnormalities. And so this is why your obstetrician brings up this testing, because he or she is required to bring it up to you. You don't have to decide to have the screening, but you have to have the conversation. Now, after that conversation, there's a very confusing smorgasbord, I would say, of options. And the testing that you choose to have is highly dependent on where you are in pregnancy. So as I mentioned earlier, you have certain options in the first trimester, you have certain options in the second trimester, and the point of all of these confusing arrows is that one size does not fit all. In certain parts of the country, it's important for women to know as early as possible in their pregnancy about the fetal chromosome status, and in other parts of the country, it's the issue of safety and not risking a miscarriage that could be associated with an invasive procedure. So they're all different ways to get the information, and your particular obstetrician or healthcare provider may have a particular way of doing things that he or she prefers. There's no one right answer, and as I said, no one size fits all. But at the end of the day, the idea is to get specific information about your particular pregnancy and whether your fetus is at risk for Down syndrome. Now, the first screening question, and this is the question that was really used as a test for many, many years, is how old are you? And that's because, as you can see from this graph, as a woman gets older, so on the x-axis is maternal age in years, and on the y-axis is the risk of having a live-born baby with Down syndrome, the line is pretty flat until you start to get into your early 30s. And then there's an inflection in the curve around the time that you turn 35. Now, why was age 35 determined to be the magic time when you would be offered the opportunity to have an amniocentesis? Well, it's because the risk of having a miscarriage associated with the procedure was approximately the same as the risk of having a live-born baby with Down syndrome. So that's how 35 got to be the cutoff. You can see that as you get into your 40s, and many women are choosing to have their children later in life, that the risk goes up quite significantly. Now, your age is incorporated into all of the screening tests, and I'll show you how that's done in a moment. So basically, this is how many of you have already gone through this, and I need to lay this landscape so you'll understand how the new tests fit into this landscape. But currently, in all pregnant women, you have the option of having what's called the Nuchal translucency test, or the NT, which is an ultrasound-based test. Then, in addition to the NT, you can have either a first trimester blood test or a second trimester blood test, or both, with or without the NT measurement. And the idea is that in the blood test, you're measuring proteins that are made by the fetus or the placenta. You're taking the measurement of the nuchal translucency, You're taking into account the mother's age, and you specifically get a risk number. This is the screen. It's not a diagnostic test. And as I told you before, if you're 35, you have an approximate risk of 1 in 270 of having a live-born baby with Down syndrome, and that's also the risk of the procedure. So on the basis of the screening test, if your number comes out to be a higher number than 1 in 270, then you're considered to be at high risk. And using this approach detects about 80 to 90% of cases of Down syndrome. But the problem is, to get that detection rate, 5% of the tests are false positives. So that means that a lot of women get the news that they have a positive screening test, or that they're at high risk for having a live-born baby with Down syndrome, when in fact their baby is normal. So that's one of the disadvantages of the current strategy. Now here I show you on the left what the ultrasound picture looks like at about 11 weeks. And you have to get the fetus sort of in an exact cross-section, which is easier said than done. It actually takes a lot of special training for the sonographers to get the fetus in the perfect position so that they can measure the space that's marked with the blue circle. I'm not sure if you can see the blue circle, but there's a space here. And there's a way that you can measure that space, and you can relate it to the actual age in days of the fetus. And if you look on the right, you can see here that this is a fetus that has miscarried, and here is the nuchal translucency. Again, it's a fluid-filled space, and this is what's being measured on the ultrasound. And there is a direct relationship between this fluid-filled space and what's called the crown rump length of the fetus. So as the fetus grows, the nuchal translucency grows, and there's a direct proportionate relationship. And if the nuchal translucency is wider than would be expected for the age of the fetus, that's a problem. And it means that something is wrong with the development of the lymph system of the fetus. And that could be for many reasons, but one of the biggest reasons would be a chromosome abnormality. So that's what's happening when you're having this NT ultrasound test. Then the blood tests, as I said, measure proteins that are produced by the fetus or the placenta. And since every laboratory has slightly different ways of measuring these proteins, the results from an individual laboratory are calculated relative to population standards. And they call these MOMs, or multiples of the medians. Supposed to be a little joke there. But what they look at is the average value, or the 50th percentile, is the equivalent of one mom. So one mom would be a perfectly normal result. There are a number of other factors that are used in the serum screening, including racial origin of the mother, because there are different relative standards according to different races, whether or not the mother has diabetes, which affects production of these proteins, whether or not she smokes, etc. These are just minor details that are used to adjust the results. And if you have a first trimester blood test, they're measuring two proteins. One is called PAP-A, pregnancy-associated plasma protein A, and one is beta-HCG, human chorionic gonadotropin, which is a hormone of pregnancy. And in the second trimester, they're measuring alpha-fetoprotein, or AFP, HCG again, and other molecules, estriol, which is a female hormone, and inhibin. And basically, it's been shown that if the fetus has Down syndrome, the values are either abnormally low or abnormally high. So PAP-A, which is only measured in the first trimester, is extremely low in fetuses that have Down syndrome, whereas the free beta part of the human chorionic gonadotropin molecule is extremely high. And these are moms again. If these results are abnormal in the first trimester, with or without the information from the NT ultrasound test, your healthcare provider might recommend that you have an invasive procedure because you would be considered to be at risk for having a fetus with a chromosome abnormality. And that test involves putting a needle either into the uterus or a catheter up through the cervix to obtain material from the early placenta. And that material is removed permanently, and then the chromosomes are prepared from that material. And on the right, you can see chromosomes here. I have an abnormal karyotype result here, which I'll just put on the full screen here. I've made it a trisomy 16 case, which is something that would be associated generally with a miscarriage. Chromosomes tell us right away if the fetus is a boy or a girl. This happens to be a boy here with one X and one Y chromosome, but there are 2 copies of all the other chromosomes. So this would not, unfortunately, be a happy result for somebody who had that test. Oh, sorry. So a lot of women like to have the CVS procedure because it's done early in the pregnancy, and therefore it restores privacy to reproductive decisions. You don't generally show at 11 weeks. So if you are at high risk for any type of genetic condition, you would get information sooner rather than later. Particularly people who have single gene disorders like this test because they might have as high as a 25% or 50% risk of having a fetus with a chromosome or genetic abnormality. The disadvantages of the CVS are that there's an elevated risk of fetal loss with this procedure. There was some concern years ago about whether this technique slightly elevated a risk of having malformed limbs. I think the jury pretty much has decided that it does not raise the risk of having a limb malformation syndrome, but it certainly is in the medical literature as a possible complication. You can also, because you're biopsying the placenta and not part of the fetus, it's possible that you could get an abnormality in the placenta that really doesn't mean that much with regard to the future health of the baby. And it's something that you would probably meet with a geneticist to discuss. Now, in the second trimester, you can have these additional markers, which again, relative to the 1.0 mom, that's a perfect result. The AFP values would be low, the estriol levels would be low, and the inhibin levels would be high. And this just shows you in an actual report what this would look like. And you can see that we take into account the age of the pregnant woman, her gestational age, her weight, her ethnic group, and the actual values are converted to these multiples of the median. Now, remember when I showed you the slide of how your risk of having a baby with Down syndrome is related to your age, because this woman is 15 years old. She's got an extremely low risk of having a baby with Down syndrome, 1 in 8,500. Now she comes back with tests that are generally pretty close to normal. I'm sorry, you know what, I reversed it. Her risk on the basis of her age is 1 in 1,200. Because her results are reasonably normal, now we can reduce her risk to 1 in 8,500 on the basis of specific information from her pregnancy. So she's low risk to begin with, but now she's extremely low risk because she's got normal values on her blood test. Now, in contrast, we've got a lady here who is 26 years old, still at low risk. Her risk from age alone is 1 in 970, so she would not qualify for an invasive test because she's low risk. But look at what happens. She's got a low alpha-fetoprotein level, a very low estriol level, and high HCG and inhibin levels. So these are all abnormal, and they're what would be expected in a fetus with Down syndrome. So her age-related risk now is raised to a risk of 1 in 45. So she's gone from somebody who at age 26 would not qualify for an invasive test, but because of the blood test results, she is now high risk. So she would be offered an invasive procedure, and it would be an amniocentesis because she's already in the second trimester. So here's an amniocentesis that also involves putting a needle into the womb. In this situation, the fluid is taken out. It doesn't harm the fetus. It's about an ounce of fluid in which there are cells floating. The cells are cultured, and it takes about 7 to 10 days to get results. And I've shown chromosomes here, but as I'll show you in a few minutes, the way of assaying the fetal chromosomes is changing to microarrays, and that's a whole other discussion. But from amniocentesis, we are actually looking at the fetus, not the placenta. The cells come from cells that are inside the mouth of the fetus or the skin or the bladder. As I said, the results take 7 to 10 days. Some of you may have had a test called the FISH test, and that's performed on non-dividing cells, and it's a quick way of figuring out whether there are abnormal numbers of chromosomes 13, 18, 21, the X, and the Y. And the risk of miscarriage, it's not 0. We used to say it was 1 in 200. There are studies that suggest that maybe it's lower, maybe more on the order of 1 in 700. But for both of these procedures, the CVS and the amniocentesis, there is a risk of miscarriage of a healthy fetus. Now, I just want to briefly mention chromosome microarrays because they are on the horizon as a way of looking at the DNA in the chromosomes. So there's discussion now amongst prenatal diagnosis providers as to what's the best way to look at the fetal chromosomes. And there was a recent NIH study that was completed this winter, and we're awaiting its publication, but it seems to suggest that in the setting where the fetus has an abnormality that is seen on ultrasound, using the microarray will allow you to pick up about 6% more clinically significant problems. So it's a way that's more detailed, and it has higher resolution, and it allows you to look at DNA rather than the actual physical structures of the chromosomes. Okay, so now that's the way things are in terms of the standard of care, and we're going to switch over to the newer technique looking at fetal DNA in the mother's blood. And I just put this timeline here to show you how relatively recent this has all developed. It was only in 1997 that Dr. Dennis Lowe in Hong Kong detected the presence of cell-free DNA in the mother's blood. My group and others had been looking for intact cells that are circulating from the fetus in the mother's blood, but that proved to be quite difficult. And what happened between 1997 and the present time is there were tremendous advances in the way you can isolate DNA from a blood sample, as well as how you could analyze the DNA sequence. And so in this slide, it just shows you that between 1980 and the present time, there was this rapid increase in the number of literally letters in the genetic code that you could analyze per day. And as the pace of the sequencing increased, the cost went down as well. So this became the game changer. There were technical improvements in DNA sequencing which resulted in lower costs and faster results. So this all happened over a relatively short period of time. It really wasn't until 2008 that we could even do this. And by 2011, there were already advertisements from a company called the Beijing Genome Institute in mainland China, where they were already advertising as of March that they had done 23,000 cases of testing for Down syndrome from the mother's blood. So it all happened over a very, very quick period of time. So what are we talking about? Well, we're talking about something that's generally referred to as NIPT, or non-invasive prenatal testing. And what we're referring to is using DNA sequencing to analyze the free-floating DNA that's in maternal plasma. So the first thing that happens is a blood sample is taken from a pregnant woman, and from that blood sample, inside the blood is a mixture of the mother's blood and sequences of DNA that are floating around from the placenta, which represents the fetus. So the first thing you do is you isolate the DNA from the blood sample. And it's cell-free DNA. It's the free-floating DNA molecules, which are shown here. Once you isolate the DNA and you prepare it, you run the DNA molecules through these slides that are called flow cells. And there's a fairly complicated process that involves literally analyzing the letters of the genetic code in fragments of DNA that have come from the blood sample. Each fragment of DNA has essentially a unique fingerprint consisting of letters of the genetic code, and they are unique enough that you can map each fragment to a known section of the human genome. So it's as if you had a giant book in front of you and you had a series of words, and let's say the words were, "The dog ate my homework." And you are looking for where in the book it says, "The dog ate my homework." And because you have a very fast-paced computer, you can quickly find out where exactly, with a scanning device, you can find out exactly where in the book it mentions that the dog ate my homework. And if you now find out that you've got lots and lots of mentionings of the dog ate my homework, that would suggest that that part of the book is present in excess. And that's what we're trying to do here with testing for chromosome 21. Because if we sequence multiple fragments from chromosome 21 and then count them, we can easily recognize if there's too much DNA from chromosome 21 than you would expect as compared to a normal sample. So if there's a relative excess here, that will result in a report that suggests that trisomy 21 has been detected. But the fundamental principles are sequencing these fragments and then counting them and measuring the counts relative to a normal standard. Now, the other thing that's important to mention is that, again, as I said, you do get maternal DNA in here. So one of the things that we're finding out is, in rare cases, we are finding out that there is something wrong with the mother's DNA as well. Now, clearly these women are normal to the point that they're pregnant, but we can find non-lethal problems in the mother's DNA just by doing this test. Now, the day the landscape changed was October 17, 2011, at least in the United States, because that was the day that non-invasive prenatal testing using maternal blood DNA sequencing became clinically and commercially available. So it hasn't even been a year. I'm speaking on September 26, 2012. It's been just about 11 months. So the test is still relatively new. And our current practice as of this month at Tufts Medical Center, where I work, is that we offer tests from 3 different companies. There are 3 companies that are offering the test. The companies are Veronata, Sequinome, and Ariosa. They are all based in California but provide the test nationally. The test clinically is being used as an alternative to an invasive procedure for women who are high risk, either because they're over age 35 or because they are screened positive from one of these tests that I've already gone into. It's considered to be an advanced screen, not a diagnostic test. If you need 100% confirmation that the fetus has a chromosome abnormality, that still requires an invasive procedure. However, women who want the test and are willing to pay for the test out of pocket are given information when they call about the test. No insurance company will pay for the test if a woman is low risk. If a woman is high risk, there are some insurance companies that are paying for the test, but we are still in an early rollout phase, so I can't unfortunately give you one satisfying answer for everybody. It's very piecemeal depending on where you live, what your insurance company is, etc. So it's best to talk to your healthcare provider about this. Any woman who has the test should be receiving pre- and post-test genetic counseling. And the test is currently offered to detect trisomies 21 or Down syndrome, the 2 other major trisomies, which are trisomy 13 and 18, and Veronata is offering a test that detects 1 copy of chromosome X, which is known as Turner syndrome. Now, this is the way we are currently offering the test. As I said, the usual client is a high-risk pregnant woman who is either over age 35 at the time of delivery or a woman who has become high-risk because of previous screening results. So the high-risk pregnant woman comes in for pre-test genetic counseling. She's then given the option of doing nothing or having traditional non-invasive screening. She doesn't have to do that. She can go directly to diagnosis if she's high risk, or she can go directly to non-invasive prenatal testing. The testing involves a blood test that is performed after 10 weeks of gestation. Once she has the testing, the results will come back as either negative, meaning there is no abnormality detected in chromosome 13, 18, 21, or the X, or the results could be positive. But if they're negative, no further testing is required. So remember when I told you back at the beginning that 5% of women who have the traditional screening are called positive, but they are, for the most part, false positive. these women would normally go on to have an invasive procedure, but if they have the blood test and they are negative, they avoid the invasive procedure. And that seems to be where the major benefit of this test is. It allows women to avoid an invasive procedure. It is therefore safer because there is no risk of a procedure-related miscarriage. Now, if the results are positive, because this testing is still new, we are definitely recommending that an invasive procedure is performed for diagnostic testing. We're also recommending that if for whatever reason the results come back as unclear or unclassified. That is a result. It is not a negative result. So for clarification, an invasive procedure is recommended. Now, again, low-risk pregnant women can enter this algorithm by having the traditional screening that is part of standard of care, and if those results are positive, the woman becomes high risk. So hopefully that is somewhat clear. Now, as soon as the test came out, the International Society for Prenatal Diagnosis came out with a rapid response statement because the society was concerned that women would be using this inappropriately and that it was still very, very early in clinical application. So they recommended that before transitioning to a wider population-based screening test, that additional testing in the research mode had to be done. So it was unclear how the test would perform in twins. It was unclear whether the test would be applicable to IVF pregnancies, whether we could provide it in a cost-effective, timely, and equitable manner, and whether it would be efficacious in low-risk populations.
Dr. Bianchi, there is a question here.
Okay.
And it says, just to clarify, is our presenter stating that this new test does not have any false positives?
Okay. So thank you for that question. There are false positives. The false positive rate is lower than with serum screening. So on average, the current false positive rate, if you take all of the different companies' results combined, is somewhere on the order of 0.1 to 0.2%. Interestingly, I'm not aware of any false negatives, meaning if there have been any women who have ultimately given birth to a baby with a chromosome abnormality who had a negative test result. But it's important to recognize that the test just became available in October, so the very first women who had the test, the early adopters who had the test last fall, the earliest they would be delivering would be in May. So it's only been about 5 months where we've had experience with live births from women who had the test and who had negative results. So that was an excellent question. Okay, so twins and multiple gestations. There's not a whole lot of information yet, but there is information to suggest that at least in twins that the testing should be able to work. But none of the companies have yet offered the testing for multiple gestations. So in terms of IVF, we addressed that in a study that I was the first author on that was published in the journal Obstetrics and Gynecology, and we looked specifically at women who conceived by assisted reproductive technology. There were 247 women who used ART, who participated in the study. Of those, 38 ultimately had the DNA sequencing, and we saw no difference in the results. We don't think that ART really makes a difference. So if you've conceived using ART or IVF, you should still be able to have this test if you have a singleton. Will this testing be cost-effective? There's a lot of discussion in the prenatal diagnosis community about this, and there have already been some articles in the economics literature modeling how this is going to work, and the bottom line is that it seems to really even out because you're doing fewer amniocenteses. The overall costs to the healthcare system are pretty much neutral. Will the test work in low-risk populations? Initially, some concerns were raised that high-risk pregnant women have abnormal placentas, therefore there's more fetal DNA floating around in the plasma, therefore the test works better. But there now have been studies that show that there's really no difference in the performance of the targeted sequencing in women who are of average risk. So I don't personally think that that's going to be a major concern. There have also been many articles and sessions at professional meetings about the ethical issues associated with this testing. And the big issue is that the test removes the ultimate fear of the invasive procedure. So there is a concern, particularly among the Down syndrome community or the trisomy 18 community, that more women will have prenatal diagnosis because they do not have to ultimately face what's called the big needle. There are also concerns about the fact that the current system allows multiple opportunities for reflection and counseling with a stepwise approach. So you get plenty of time in the current algorithm to think about what you're going to do, whereas with a blood test, it's pretty instantaneous. You have the blood test, you get the results back, and then you don't really have to spend as much time with the next step. So there are people who feel that that's a plus, and there are people who feel that that's a minus. There's also concern about whether more women will terminate their pregnancies. And, whether because the test is less risky, will that mean that more women will have the test, and therefore more women will find out that their fetuses have a chromosome abnormality, and therefore they will have termination? I think it's very hard to say whether that will happen. I think it will be balanced against the fact that there will be fewer unintended miscarriages of healthy fetuses due to the significant reduction in the invasive procedures. The clear benefit is for the women who have the negative sequencing results who don't need to go on to have an invasive procedure. The other thing is that the recent trends from the United States show that there is really no change in the number of babies being born who have Down syndrome. And so even with the availability of newer and better techniques of prenatal diagnosis, there has not been a decrease. If anything, there's been an increase. It's estimated based on recent contemporary U.S.-based studies that about 40% of women who have a fetal diagnosis of Down syndrome will continue their pregnancies. So I think it's hard to say how this test will affect both clinical care and the demographics of babies being born with Down syndrome. It's something that we'll clearly be following. And the Down syndrome community is very concerned about potential devaluation of affected individuals with trisomy, and that's certainly a valid concern. So in summary, I wanted to mention that this non-invasive prenatal testing is available currently, so it is the present, but it's also the future. I think one of the things that many of us working in this area have been surprised about is the rapid uptake by patients and the fact that patients are going to their physicians to ask for this information, and in many cases the physicians don't know anything about it. It's currently being used as an advanced screen for aneuploidy, which means an abnormality in the number of chromosomes in high-risk women. And as I said, it's safer because it reduces the number of invasive procedures. It performs better than the standard of care because there's a lower false positive rate, but it is more expensive and complex. And transitioning to a primary screening where all women start with this test or making it into a diagnostic test is really too premature. We don't have enough information. Whether either of those options would be appropriate, it requires more data and clinical experience. So the last thing I just wanted to show you is that here's a summary of the stepwise approach where currently women are having screening, having the opportunity for reflection, then they're having an invasive procedure, and after post-test counseling are deciding what to do with their pregnancy, whether to terminate or continue their pregnancies. And there are many benefits of knowing ahead of time if your fetus has a chromosome abnormality, because you can prepare for the needs of that child and you can plan your delivery at a hospital where the appropriate specialists are available. But in the future, whether or not sequencing does get incorporated into the prenatal algorithms, the hope is that there would be a third option and that it would be possible to provide treatment for the particular chromosome abnormality that the fetus has. And that's something that we are in the very, very early stages of studying and testing for in a mouse model in my research laboratory at Tufts. So that's the end of my prepared comments. I know we have a lot of questions. So.
Yes, thank you so much, Dr. Bianchi, for all this great information. We do have a few minutes for questions, so I invite our participants to type those questions into the chat room. And while you're doing that, participants, Dr. Bianchi will be answering some of the questions that were pre-submitted prior to the webinar.
Okay, thank you, Chris. So the first question is there a certain age that expectant mothers should have this test? So I hope I did make that clear in the presentation that if you are over 35 at the delivery of your child, you would be considered high risk and you could then ask for this particular test. There's no magic age. Again, it's a combination of the age as well as the prior screening tests that could make you high risk, even if you're under age 35. Is it more probable that women over 35 should definitely have this test? As I said, the only thing that's definite is your healthcare provider has to give you the information on the test. You decide whether you want the information from the test or not. So there's no definite on our end. It's on your end. Then the next question is, do all doctors include this test in prenatal visits, or do women have to ask for this? Well, as I said, the test is relatively new, and many primary obstetricians and healthcare providers still don't know a lot about it. The maternal fetal medicine community is offering it. Genetic counselors are offering it, but the general OB's office in many cases is not offering it yet. So if you do want to have the test, you probably should either contact your local genetics unit or ask your healthcare provider about it or go to one of the company websites. Interestingly, the test is not yet offered by any of the academic laboratories. It's a little bit unusual in that the test is only available through various commercial organizations. Then the next question is, are there any instances of false positives, false negatives? So I mentioned that overall there's about a 0.1 to 0.2 false positive rate and a 0% false negative rate. The performance for Down syndrome is the best of all the chromosomes. The detection of Down syndrome is between 99 and 100%. So it's much better than the current screening tests, which detect between, say, 80 and 92% of cases of Down syndrome.
Dr. Bianchi, I see we have a couple of questions, too, in the chat room. One is it necessary for everyone to have genetic counseling prior to having this test?
Well, not genetic counseling per se, but pre-test counseling. So it doesn't have to be provided by a genetic counselor, but someone who is familiar with the benefits and the limitations of the test should be advising the person who wishes to have the test.
And one more is, do you believe non-invasive prenatal testing will ultimately replace serum testing?
I don't know, honestly. I think that, the performance is better, but it is a complex way of doing things, and it is expensive. So, I think that there are many advantages of the current algorithm with the serum screening, particularly in rural areas. So I think it's premature to say it'll replace it, but it is certainly rapidly becoming part of the algorithm of prenatal care. I did want to, somebody had written in about whether the test could assess for mosaicism. So mosaicism is when the fetus has more than one chromosome finding in different parts of itself. So you can have more than one type of result, and the test can assess for mosaicism. What is the turnaround time for test results? I think most of the companies are at the point where they're providing test results in about 7 business days. At what gestational age can the test be performed? Anytime after 10 weeks. The cost of the test, people are wondering about that. That is also, unfortunately, not a one-size-fits-all answer. It could be anywhere from nothing out of pocket to $1,200 out of pocket. In general, most of the companies are asking for a small, relatively small, I should say, co-payment or down payment, but it's different. Again, unfortunately, I can't give you one consistent answer because it has to do with local state regulations and various insurance providers. But there is an active effort on the part of all of the companies to get coverage by insurance, and there has been some progress in that area. Somebody said, is there any situation where you would recommend amniocentesis? And I would say that if you want 99.99% certainty of the fetus's chromosome status, you would want to have an invasive procedure, which would be either amniocentesis or CBS.
Dr. Bianchi, we have about another minute or two for questions, and I see one here. It says, should general OBGYN start offering this test to high-risk patients?
Well, again, if the obstetrician feels that they understand the test and they are comfortable with the benefits and limitations, I see no reason why they could not. Somebody needs to provide the pre-test counseling to the patient. So assuming that the obstetrician has had education and feels comfortable with how the test is provided and could answer the patient's questions, then I don't see any reason why not. Okay, so I think that there's one last question. Would this be a suitable substitute for the new sequential screening most maternity care providers are offering? So the sequential screening is this combination of first and second trimester blood screening. So that would be part of the primary screening. So again, this DNA testing is not a replacement for the primary testing. It's a secondary test at the time that the discussion occurs related to the invasive procedure. So it is not a replacement.
All right, thank you again, Dr. Bianchi. To all our participants, we come to the end of our presentation tonight. Please remember to check your email for the webinar recording. We'll send it out within about 2 days. And again, a big thank you to Dr. Bianchi for sharing this valuable information with our audience tonight.
Thank you, Chris and Nancy. It's been a pleasure working with you.